Hello, thank you all for joining us for our 5th Bipolar UK Cardiff University Centre for Mental Health Research webinar. And this week we are looking at pregnancy in bipolar, women in bipolar. And it's a topic that comes up a lot of the time within our community, within all of our forums, within our support groups. It's a topic that so many people find is a very contentious topic, a very difficult topic, but hopefully today it'll be a topic that we'll cover, which will end up also bringing hope to people as well. Because I know it provides a lot of anxiety, and hopefully with our excellent panelists today, we'll be able to give you some reassurance. If you're someone living with bipolar, who's a woman who's thinking of getting pregnant or is pregnant, what it might involve, and then what you'll be able to potentially some of the things you can do to plan ahead and so forth. In terms of my lived experience, I'm Simon Kitchen. I'm the Chief Executive of Bipolar UK. I myself am not actually personally living with bipolar, but I work with lots of colleagues, wonderful colleagues and volunteers who are living with bipolar. We have a connection with it within my family. Really interested to hear what the panelists have got to say today, because my wife gave birth last year, which is a really magical experience. But I can testify that pregnancy and childbirth is probably one of the most stressful things that I've ever been through, and I wasn't even the one giving birth. So what it must be like for someone living with bipolar who gives birth, it must be a really difficult experience dealing with this. Used to do with like the stress of it, also to do with sleep deprivation, and then also all the physical pain as well. So I'm really pleased that we've got an excellent panel who can talk with great insight and expertise on this. So we've got Dr. Clare Dolman, who's done a PhD. It's her specialism, dedicated her life to being able to help understand women in bipolar and postpartum psychosis in particular. She herself has got lived experience as well, which brings a real vital insight to this. And we've also got, I think it's is it Dr. Ian Jones? Or just Professor Ian Jones? He's a professor psychiatrist.
Anything you like, Simon. I'll take any label. I don't mind. Just cool. Just
brilliant. Yeah. Ian, on first name terms now, after having done so many of these. Ian was Clare's supervisor, and he persuaded Clare to do the PhD. So the two of them have got a really good kind of working relationship. So hopefully they'll be able to kind of feed off each other's positive dynamic here. Those of you who have attended these in the past, they're obviously free. We want to make sure these free going forward into the future. We know a lot of people with bipolar don't have a lot of money, so that's why it's really important that they are free. But if you are able to donate, we have a text donate function, which our lovely Kat's going to be posting in the message board. For those of you who are just listening in, it's just need to send text bipolar to 785 or bipolar no info to 785 if you would like to donate but wouldn't like to get kind of marketing information from us. And it would be a £5 donation, only the price of a very cheap mid-range Starbucks coffee. So if you value what you hear today, then please do donate so we can run more of these. So I'll now hand over to our wonderful panelists. So Clare, would you like to take it away now?
Hi, thanks very much, Simon. Yeah, well, thanks ever so much, everyone, for joining us this evening. And as Simon said, we're very lucky to have Professor Ian Jones with us, who is a world expert on this subject and also a huge friend to the charity Bipolar UK over many, many years. And he's going to outline some of the main things that you need to think about when you're considering having a baby if you have bipolar. And many of you probably know that childbirth can be a trigger for an episode, sometimes a serious episode. So Ian's going to talk us through some of the challenges and what you can do about them and give us an idea of where we are with the latest research. And when you hear all of that, and when we've been through some of your questions and whatnot, what you really need to do is think about how all of that information relates to your specific circumstances, because we're all completely different with different medical and family histories, And those things are all very important when you're thinking about planning ahead. So after Ian's talked about the medical issues and ways in which you can perhaps increase your odds of staying well during pregnancy and the birth and beyond, I'm going to add my tuppence halfpenny worth as a woman with bipolar 1 who ended up in hospital after the birth of my first child, but managed to avoid it the second time by taking various steps to stay well. And hopefully after this session, you'll feel more confident about making the decisions that are right for you and your family. But the most important people here this evening are all of you. So most of the webinar will be given up to hearing your questions and comments and trying to answer as many of them as possible before 8 o'clock. We've already received some, and you can ask more questions on the Q&A tab. But if we don't get through them all, we'll try and put them perhaps in on the website. I'm intending to do a blog, so perhaps we'll try and deal with some of them there. So over to Ian to introduce the issues and give us the benefit of his vast clinical and research experience on this subject.
Fantastic, Claire. Huge thanks to Simon and Claire for those very kind words. Not that I deserve any of that. I'm going to share. I've got host disabled patient participant screen sharing, Kat. Is that an issue we can sort out quickly, or shall I?
Should be sorted now.
Thank you. There you go. This proves we're live, you see. If you had any doubt, yeah. Excellent. Thank you very much. Claire, are you seeing that?
Yep.
Excellent. So, as Claire said, I'm going to talk to you for about 10-15 minutes or so about some of the issues, and I'm going to talk a little bit about some of the things that we know about the risks to women with bipolar disorder, and finish off by saying something, as Claire says, about what you can perhaps do to really kind of deal with that and minimize that as far as possible. First point I wanted to make is that this link between having a baby and suffering from significant or severe episodes of mental illness is not something that has been thought up in recent years as new ways to sell medication to women. This is something that's been written about, known about for hundreds, if not 1,000 years. And certainly when medical textbooks were began being written in Europe, there are accounts of women who had these recurrent severe mood episodes in relation to childbirth. When we think about what episodes can occur in relation to childbirth, certainly women with bipolar disorder may have episodes in pregnancy, but the particular period of high risk is the postpartum period. Now, when we think about episodes after childbirth, we think about the baby blues, which I'm not going to say anything more about, other than it's very common for many women to have some mood symptoms at this time. There's postnatal depression, postpartum depression, occurs in about 10 to 50% of women, and can become quite severe, but often responds very well to treatment, and the same treatments that for depression at other times, whether those talking treatments, psychological therapies, or medication. But the particular issue sometimes we worry about with bipolar disorder is these very severe episodes, which used to be called puerperal psychosis, but nobody could spell or nobody could say puerperal psychosis. And yeah, I've had many referrals for women with a history of purple psychosis. So we've kind of become a little bit American here and used the term postpartum psychosis. And these are significant mood episodes occurring very often in that with close relationship to childbirth. Happen around 1 in 1,000 women in the general population, but in women with bipolar disorder, that risk is much higher, perhaps something like 1 in 5, 20%, 200 per 1,000. An important point to make is that for many women, who experience postpartum psychosis, it might be their first experience of a significant episode of illness, although often, where women can identify episodes in their past that where they may have been unwell but not come to the attention, clinical attention. So when we talk about postpartum psychosis, onset quick after delivery, the symptoms are of a manic, of a high mood, or a depression with psychosis, but more often than other times we see what sometimes we call mixed episodes, where the symptoms of depression and mania are all mixed up together. And there's a really term that's used in the old literature that's really descriptive, I think, that these episodes of postpartum psychosis were said to be kaleidoscopic. Now, if you can remember looking through a kaleidoscope as a child and turning it, the pattern's continuously changing. And that really is a very characteristic feature of illness at these times, that women tend to become ill very quickly. Women can go from being very well to as ill as we see people in mental health services within a matter of hours. And they can change very rapidly with kind of lucid intervals, when they're much better. Good news is that these episodes have a really good prognosis, that women recover well, but are at high risk of episodes in further pregnancies or episodes not related to childbirth. Now this, Simon's already referred to Clare's fantastic PhD, and I was very privileged, along with Louise Howard, who's the main supervisor, to be involved with that study. And Clare did a fantastic qualitative study asking women with bipolar disorder about their experience. And what really was one of the themes that came out of this great work was that women had difficulty in finding the information that they need, which is one of the motivations for us to put this webinar on this evening, to really try and increase the information out there to women. But I think that's one of the real reasons why we need to do better to understand these illnesses and to get that information out to women. So what do we know? I'm just going to pick out a few issues to highlight in the talk, and I think probably many more will come out in the question and answer and the discussions between myself and Clare. First point to make, though, is that although in the last couple of decades there's been some question, some doubt about whether mood disorders as a whole, particularly depression, is any more common in the postpartum period than at any other times. Certainly when we're thinking about postpartum psychosis and those kind of more severe episodes, there's no doubt that the postpartum period is a period of high risk. The red graph there comes from work of Robert Kendall from Edinburgh in the 1980s that showed this massive increased risk in women being admitted to psychiatric hospital in that immediate postpartum period, those first weeks after delivery. And interestingly, that's work from 40 years ago now, 30 years ago, 30 years ago. But actually that work's been repeated across the whole of Scotland in more recent years. And again, a similar increase in risk has been found. So that's the first issue. Second issue is that women with bipolar disorder are at particular high risk at this time. This is work from a wonderful colleague, Trine Munch Olsen from Denmark, who's done brilliant work linking up the registries that they have in Scandinavian countries for childbirth with the registry for psychiatric contact and admission. What she's shown, and is illustrated on this graph, is that women with a history of bipolar illness, so women that have had previous contact with psychiatric services before they have a baby, are at a very high risk. That top red line shows that around 1 in 5, around 20% of women are admitted to hospital who have a bipolar diagnosis in that first postpartum month. So there's something about bipolar disorder that puts women at risk. And I think one of the things that we'll come back to throughout this hour is that shouldn't be a source of too much anxiety. That shouldn't scare people off trying for a family, but it's important to know that, to have that knowledge and to plan and act with that in mind. Other thing that we know is that rather than bipolar disorder as a whole, there seems to be a particular risk with the bipolar 1 form of the disorder. The risk of postpartum psychosis is highest in women with bipolar 1. Those are women that have severe high episodes, the manic episodes, rather than the risk women with bipolar 2 who have less severe high episodes. Important point to make though, and this is work from our study in Cardiff, is that women with bipolar 2 disorder are still at quite high risk of mood disorders in general, including depression in pregnancy and the postpartum period. But it does seem to be that it's women with bipolar 1 that are at the highest risk of those postpartum psychosis episodes. And then the other really important point I just wanted to bring out from the research that we've done is that it's those really those first postpartum weeks are at the very high risk period. The risk of depression tends to be spread out through pregnancy and in the whole of the postpartum period through the months after delivery. But thinking about the risk of manic, of psychotic episodes of postpartum psychosis, yeah, it's the first postpartum week. This is work from Jess Heron, who's now Director of Action on Postpartum Psychosis. And when she was a PhD student with us in the group, she published this paper that showed it was that when you ask women with postpartum psychosis when it was that they first noticed that they were becoming unwell, it was the vast majority, over 80%, were in that first postpartum week. And for those in the first postpartum week, it was day 1, day 2, or day 3 that the highest risk. So, you know, another really key point is it's that immediate postpartum, those days and weeks after having a baby, that's very high risk. So just to say something about what the research that we're doing, I think Kat will send you out a link that for those of you interested in helping with our research, it'd be fantastic if we could get that help for you to volunteer. We're doing a lot of work to try and understand and to try and understand better how to individualize that risk to help women make those difficult decisions that they have to about becoming pregnant, about taking medication. But we're also doing some work, and Ellen there is leading this to try and take some of this work that we've done and help and explain that better to women. Yeah, and we're looking for women who are thinking about pregnancy, who have bipolar, lived experience of bipolar, to help us develop those tools better. So I said before I finish, I hope I've not, I've got another minute or two just before handing back to Claire. What should you do then as a woman, or a couple? I think one of the most important things you're doing is becoming informed. Coming to this webinar this evening, I think, is a fantastic example of that. So be informed, as much as you can. Be prepared as much as you can, and I'm sure Claire will have more advice to say about this. And then I think it's really important that everybody involved in your journey through pregnancy and the postpartum period is aware of the issues, aware of your lived experience of bipolar, and that's everybody involved in the maternity services, your midwife, obstetricians, everybody involved in primary care, your GP, your health visitor, and your mental health services as well. I think increasingly across the UK now, there's been a big investment, which is fantastic news. Not least due to the work that Clare has done as a campaigner on this front. Setting up specialist perinatal mental health services. So I think ask about your locality. Is there a team? Perinatal services will want to know about you if you're a woman with a lived history of bipolar disorder as early as possible to work with you to reduce the risk. Ask them about access to a mother and baby units. What would happen if you became severely ill and needed admission to a hospital? Talk about these things. And then I think the things to talk to your team, to your clinician, to your psychiatrist, hopefully to your perinatal mental health team, are issues around when it would be best to start to think about planning a pregnancy. Normally, it's really good to think as early as possible to maybe make some of those changes in your medication that might be needed to put you in the best place. Think about issues such as sleep and stress, which we know can be important triggers. And Claire, I'm sure, will have more to think about this, and know how best you can get help at all if you were to become ill at all stages through this process. So those are kind of the thoughts I had. Those are a few issues I wanted to highlight in the talk. You know, I put some websites up there, the fantastic Bipolar UK. Most of you will have come to us through Bipolar UK, so we'll know about the brilliant work they do. I'll just highlight Action on Postpartum Psychosis, which again, there's some great information there. And then there's more information about helping with research. You can look at the BDRN, Bipolar Disorder Research Network website, and our centre in Cardiff that is co-hosting these webinars with Bipolar UK, the National Centre for Mental Health. So with that, I'll hand you back to Claire for what really is the important issues that we're going to cover, which is, you know, Claire's both her lived experience and her experience over many years of helping other women and couples in that situation. So let me hand back to you, Claire. Thank you.
Thanks, Ian. Fantastic. Just trying to, there we go. Great. Hi, yeah. So I hope from that you've got a really good idea about how seriously you have to take this. But as Ian says, there's still an awful lot of hope. You know, you can get organised, you can plan, you can work out what's the best way to approach it for you, and, you know, get all the advice you can. And you don't need to you know, get too stressed about it if you get really organised. So just to give you a little bit about my background, I was diagnosed with bipolar 1 at 23 after probably about 8 years of escalating mood swings. And I was always down in the winter and up in the summer. I was carted off to psychiatric hospital when I had a severe mania, and I was there for a couple of months. And I do remember an incident before I was discharged when I had a session with a psychiatrist who wasn't the usual one who saw me. And he said to me that I had to accept that living with a serious chronic mental illness was what was ahead of me now, and that it would affect my whole life in lots of ways. And you know, I was just sort of coming through the fog of all the medication and everything, really. And I said, what do you mean? You know, and he said, well, for example, you probably won't be able to ever have children. And I must say that is the thing that I remember from my months in the hospital more than anything else, because it just knocked me completely backwards. You know, as a 23-year-old who's in a long-term relationship and things were, you know, looking quite good up until then. I come from a large family. Having children had always been part of what I saw as my future. So I was absolutely gobsmacked. And but thankfully, when my regular psychiatrist came back from holiday, I asked him about this. You know, it was the first thing I asked him. And he said that he didn't agree with that, and that we should see how I got on. And I must stress that, you know, this was a long time ago, but as Ian sort of said, I have done work in this area since then, and in researching this subject and interviewing probably about 100 women now with bipolar, both for my PhD and other projects. Unfortunately, occasionally women still do get told that. I even spoke to somebody 2 or 3 months ago who was told that. Though thankfully it's now much rarer. So being positive about, you know, that wasn't the case, and I've had my kids, and I'm absolutely thrilled that he was completely wrong. But I am extremely lucky because I was put on lithium when I was in hospital, and I'm one of the sort of only a percentage of people, about a third of people, for whom lithium works fantastically. And, you know, for me, I had no side effects, except, I suppose, minor cognitive dulling, I suppose you call it, which I've sort of tried to deal with. So I came out of hospital, I got on with my life, I trained, worked as a newspaper journalist, I got a flat, I got married. My husband, Ed, and I were very keen to start a family. So I asked a psychiatrist who I just saw every 6 months for my sort of checkup about it. And she said I had to come off my lithium before trying to get pregnant, as it could be harmful to the baby. And that is not advice that is necessarily the case now, because there's been more research on that subject. But I did taper off my lithium, and luckily I stayed well during the pregnancy, but problems arose after the birth. The birth went reasonably well, but I had a thrombosis in my leg, so I had to stay in for a couple of extra days. And as I was on a busy 4-bed ward, it meant that I hardly slept for 3 nights. And I thought, I'll be okay if I get home, but it didn't go quite to plan. And because I'd been off my lithium for, I suppose, about 11 months or so, without a problem by then, I decided it was fine. I was fine to breastfeed. You know, breast is best. I've been to NCT, antenatal, you know, it's pushed at you the whole time, etc., etc. But unfortunately, that was a big mistake for me. It was a big mistake. And obviously, feeding meant that my sleep was even more disrupted. My mood started swinging about. I was elated 1 minute, irritable the next. And Ian, I think, would describe it as a mixed episode, as he was saying that postpartum psychosis often is. I was staying up all night, apparently writing a novel, and I became increasingly paranoid. I had mild hallucinations. But both me and Ed, my husband, recognised that I was getting ill and the episode was escalating. So we got help, and after a few problems accessing secondary care, it led to spending 5 weeks in hospital. But to be honest, I think Ed was more upset and traumatised by this than me, because I was so exhausted that I mainly felt total relief to be able to go to hospital where I knew I'd be safe. I knew the baby would be safe with Ed and my family, and I could sleep, and I knew that they'd get me back on track. So although I only spent 5 weeks in hospital, I wasn't really right for a few months after that when I came home. And I was extremely glad of the support of my family, which I think you really, really need at this time. But it hadn't affected my bonding with my daughter, thank goodness. And after about a year, I was ready to give it another go. But this time, I made sure that I planned ahead better, and I discussed it with my psychiatrist, and I agreed that I should go straight back on my lithium as soon as the baby was born, and bottle feed so that I could get my sleep. And because I knew how critical sleep would be, I also arranged for a relative to move into the spare room and do the night feed for a fortnight, so I could get back into a sort of rhythm. Well, it worked. And my son, Alex, was fine, and so was I. So although my kids are grown up now, I think the thing that you need to think about if you're a woman with bipolar planning to have children haven't really changed that much. The difference now is that there's thankfully a lot more information available. There's more research on medications, although, you know, there's still a lot needs doing. And there are, in England at least, much better perinatal mental health services, thank the Lord. And as Ian was saying, those of us who've been campaigning for years for this improvement, Ian and me and hundreds of others all over the country, we're all absolutely delighted that this is happening, but things really still need to go on improving, and there's still work to be done, especially in Northern Ireland, Wales and Scotland. So if you're joining us from one of those countries, do send in your questions, and it'd be great to hear from you. But before we get to the questions, I'm just going to run through my top tips for staying well, some of which overlap with what Ian said. But number one's got to be plan ahead. And if you're able to see a specialist perinatal mental health team, as Ian said, for that essential preconception advice, which you're entitled to in England. So make sure that you go to your GP or your psychiatrist to refer you, and don't even in these COVID times, don't think, oh, they're not going to be bothering with preconception referrals, because they are. I mean, there's certainly 2 or 3 teams that I've spoken to about the COVID situation, so that they are still keen to consult with women and couples, and of course they can do it by Zoom now. So make full use of those appointments. You quite often will get 2. You get a preconception one, and then you get another one hopefully when you are pregnant, and you can discuss the details of the birth and postnatal period in more detail. I'd also recommend writing an advance directive or statement, so that you can cover some of the issues that might arise if you do become unwell. And you can find a blog about this on the Bipolar UK website by Tanya Gergel, and there's a video interview with friends of mine, Henry and Jenny, who they very kindly did a film talking about how doing this really helped them. Writing an advance statement really helped them when she had to go into a mother and baby unit after the birth of their 2nd child. So number 2, try to avoid major life changes like moving house, which obviously is often on the agenda because of needing more room, if you're having a child. But really think about it, because it might be better to wait a year or so. The baby won't mind. They won't be at that stage yet to worry about it. And I moved when I was 6 months pregnant, and then we had loads of DIY to do and all that kind of thing, and it was really stressful trying to find a house in time and things. So I slightly regret it now. Number 3, minimize your stress if you can, in your pregnancy, whether that means taking a bit more time off work or changing your hours if you possibly can, or practicing, things like meditation, yoga, mindfulness to stay calm. A lot of people find that really helpful. Number 4, we can't say it more, anymore. Sleep is of paramount importance. And I know that this is pretty obvious to most of us who have bipolar, but try to keep it constantly in mind when you're planning things, because, for example, when you're thinking about how things are going to happen in hospital and what kind of birth you're hopefully going to have, etc., it's really good idea to ask for a private room, because then maybe you're more likely to be able to get that sleep that you so desperately need. And if you do decide to breastfeed, because a lot of medications you can breastfeed with, perhaps investigate mixed feeding or an expressing, so that you can have a break sometimes, or your partner can do some of the night and that kind of thing. But find out about the sterilizing equipment and all that kind of stuff, so that it's not all a rush if you are not very well. And number 5, related to that, if you can, organize help for when you have the baby. And I would really recommend this if it's at all possible. Don't try to be super mum. Nobody is. Ask for help, and if you can get someone to help with night feeds for a couple of weeks, then be grateful. Don't feel guilty about it. Just I mean, I absolutely loved it. It was great. Number 6, consider carefully the pros and cons of breastfeeding in your particular situation, because it's not just about whether you can breastfeed on your particular medication. I mean, I was keen to do it, but in retrospect, it would have been wiser to bottle feed and start back on my lithium immediately my daughter was born. But, you know, so do take into account how disruptive of your sleep the breastfeeding is going to be, because it is a really big thing. Number 7, try to get home to a more relaxing atmosphere as soon as you can. And whether you have to stay in hospital for a bit or whether you're at home, don't have too many visitors. Involve your partner so that he or she can judge whether you're getting overtired or overstimulated. Right, that's it. 7, not a very good number. Obviously, some of this is common sense, but planning ahead is just such a good idea. And it can help you to stay calm during the pregnancy and birth too, because you'll feel more in control and reassured that you have backup plans in place if things do go pear-shaped, and you're not completely thrown if they do. And that's quite important for your partner as well, because you know, especially if perhaps he or she isn't very familiar with your illness or what, you know, mania is like or anything, it might be quite traumatic for them, or they're not really, they just sort of feel at sea the whole time, that they don't know what's going to happen or what to do about anything. So if you have a really good plan and you sort of have backup plans, that will probably make them feel more reassured as well. It goes without saying, I suppose, when you're planning for a baby, that you need to be as physically healthy as you can. Don't smoke, don't drink, etc. You know, you get told you can't do anything anymore. Do moderate exercise, try to eat well and keep your weight down, which I know is difficult on certain medications. But if you can't, you know, don't put pressure on yourself, again, to be the perfect mum. It's not the end of the world if you don't breastfeed, or you're a bit overweight, or you need some extra help. Because at the end of the day, to be the best mother to your child for the whole of their life, you need to take really good care of yourself around the birth. Excuse me. And if you're confident and you're well prepared, you're much more likely to be able to relax and enjoy your baby. And your partner, you know, as I said, will have a better idea of what might happen. So those are my top tips. And to help you plan ahead, there are some great resources. There's the ones that Ian's talked about and shown you on there. But there's quite a few things that it would be a good idea to take a look at, perhaps at Bipolar UK's website, the downloadable leaflet that we've got up there. And as Ian said, APP, for it, especially if you've already had a postpartum psychosis and you're keen to avoid another one, or you need more support. I particularly recommend the leaflets on the Royal College of Psychiatrists website on perinatal mental health. They're really, really great, and they're quite up to date. And most recently, also the fantastic resources on the Tommy's charity pregnancy hub for women with serious mental illness. That's just been completed in the last few months, and that was Professor Louise Howard that Ian mentioned of King's College. She was in charge of that, and they're really that's really good resource, so do take a look. And I'm going to put links to these resources in a blog to accompany this webinar, which will be up on the Bipolar UK site next week, I hope. So now let's get stuck into the question. Simon, over to you.
Brilliant, Claire. That and Ian, that was fantastic, and I learned so much just watching it there. Actually, quite a lot of the questions that have come up are ones that you've actually been kind of like going through answering as you've been going along, which is a good thing. I mean, the key thing that has come up on a few questions are people asked about breastfeeding and sleep. Getting sleep during the third trimester as well can also be difficult. I know from my experience when my wife was in hospital, I was staying in as well. The first week, the baby was in intensive care, and so we were sleeping. We did actually have a private room, but the thing that certainly struck me was that all of the amount of times that we got knocks on the door when you're just trying to get off to sleep, and then you get someone knocking on the door asking what you want for your breakfast, knocking on the door to bring you breakfast, and knocking on the door to take it away. And you're probably getting about 3 or 4 knocks every hour, which actually makes it impossible to get any sleep. It'd be good. So if you've got any advice for people in the third trimester, and then anything around that experience within hospitals at all, and whether that's a common experience, and whether people living with bipolar can actually just say, please don't knock on my door, I need to get this sleep over the next couple of hours. Claire, I'll direct it to you, and then you can direct it to Ian.
Okay, okay. Yeah, I was just going to say about that. I mean, I certainly, I know that some midwives now, they're much more tuned into that, and they will sort of like put a note on your door and that sort of things, asking people not to, you know, knock all the time and things like that. So it's certainly worth making a point of, you know, asking if somebody could do that for you, because it's really helpful. Ian?
Yeah, I suppose one thing I'd say is I think these are really important issues, as Claire's highlighted and I've highlighted. But what's really important when we're thinking about having a baby is however much planning you do, however much prepared you are, you just have to go with the flow sometimes, yeah. And I think one particular point I wanted to highlight is many women I see who've had an episode in relation to childbirth want to try and find the reason, or find what they did or should have done better, or sometimes it's just there's nothing that that people have done wrong. It's just one of those things. We know that this is a really high risk time, so I suppose, Claire, you'd be the same. We'll have seen many women that sometimes feel a lot of guilt about it, as if it's something that's they're responsible for. But I really think that that's unhelpful. And again, with the sleep thing, is all of these things are really good advice, you know, to really think about discussing that with your midwifery team, with your obstetrician. Think about that with your partner, with your family, with anybody that's going to help. But actually, you know, the reality of it is it's really, really, really difficult, you know, and the sleep is going to be disrupted when you've got a new baby. So you can just do your best. Is that fair, Claire?
Yeah, definitely. Yeah. I mean, we don't want to be too negative here. I mean, we're talking about 20% maybe of women with bipolar, you know, having a postpartum psychosis, but, you know, that means that 80% don't. And you've got to focus on that. And also, I always think that, you know, that 20% in the research are people maybe before we sort of some of all this advice and extra info and, you know, how to try and avoid it has come on board. So, you know, hopefully that figure might get better.
Thanks, Kenny. And presumably, Claire, there's a lot of the resources about breastfeeding and sleep and so forth. Is it all in those resources you'd be sending across as well to help people weigh up what is quite a very difficult decision to make, isn't it?
Yeah, it is. I mean, I feel quite strongly about the breastfeeding issue, because I've talked to so many women who do, like Ian was saying, you know, this unhelpful guilt, that women feel so guilty about not breastfeeding, that they're not doing the best for their baby and that kind of thing. And really, they are doing the best for their baby if they are keeping themselves well. Because if you think about it practically, you know, if you force yourself to breastfeed and stay up all night and etc., and you become really seriously ill as a result, then you're probably going to have much heavier meds, you know, which you're going to stop you are going to not be good for the baby either, because you might have to go into hospital or something and be apart from the baby because of it. So, you know, it's better to be pragmatic about it, in my view, and think about, weigh up whether, you know, whether it's the best thing to do or not.
Thanks, Claire.
I agree with that. I think that's a really important point, is that there are no right or wrong answers here. Yeah, often I think it's always a matter of weighing up the, you know, the risks and the benefits in any situation, and these are the discussions that women and their partners need to have with their medical team. There are really difficult decisions that women face about taking medication in pregnancy, about taking medication after the baby is born. But you know, you know, I really support what Claire said then about making the best decision for you. Yeah. And that issue about feeling guilt is really a big problem that you know, yeah, and what's really important for me and Claire today, and for all that we do, is to help women not feel that guilt.
Definitely.
This next question might be more for a midwife, but is from your evidence and research, is it better to have a C-section rather than a natural birth if you have bipolar? Is there any evidence in that area, or no evidence for you to be able to make any judgment?
Shall I take that, Claire?
Yes, please.
Yeah, so it's a really often asked question, actually, in the clinic, the preconception clinic I do. The research doesn't support that having a C-section is any less or more risky of having of triggering an episode of illness. We know that there are, you know, women sometimes say, well, there are benefits in that if I have an arranged section, I know you know, I will have it in the day, I won't be labouring all night, I'll be able to arrange, you know, with family, with work. But actually having a C-section is a big operation, you know, it's a big thing. Yeah, it's a big stress to go through as well. So yeah, I think that the decision, there is, you know, having bipolar isn't a reason to have a C-section. I would say some women, you know, need to have a C-section for other reasons, and that's fine. But just having a lived experience of bipolar disorder shouldn't be on that list of things that mean that you should have a C-section. Claire, is that?
Yeah, no, I do agree with you, but I mean, I think it is something that a lot more women, certainly in the last couple of years, seem to be considering, and particularly if they've had a really difficult first delivery, you know, and had a postpartum psychosis or severe depression or something after it, and they very much feel that a lot of the reason why they had it was because you know, they had sort of such a elongated labor, and they didn't have and they didn't sleep for 2 or 3 days or whatever. And you can completely understand in that circumstance, I think, why they would want to go for it. I mean, and I've spoken to women who say that their team is advising them to do that as well. Their perinatal team is advising them to do that, and then they're trying to convince you of the obstetrician of that. And so I think it is more common, but I would have thought it's more in that sort of circumstance where it's almost like, you know, women who have birth trauma because of what they've gone through, that because of that related to their bipolar, because of it then triggering an episode, they then feel like the second time they would feel so much more reassured about that not happening again, which is understandable.
Thanks, Claire. Now there's a topic which we decided before we had the call that we were going to try to avoid, but it does come up a lot, so we have lots of caveats. So it's obviously around medication. Now Ian can't advise people on their individual circumstances because everyone's medication is different, everyone's physiology is different. We'd always advise whatever Ian says, that you'll go to your psychiatrist and your pharmacist before making any changes, of course, because they're the ones who you work with on this. But Ian, it does come up a lot about what type of medications what are the implications around medication and childbirth. And I know there's certainly some medications that women really need to avoid in all circumstances if they're trying for a baby. So it's probably worth flagging those ones, and then the kind of the relative risk around the other ones as well.
Yeah, I think it's a massively important issue, and by saying that it's not something we want to cover, I think what Simon was saying there, which is right, is that we can't in a situation like this give detailed advice on any woman's particular combination of medication and say anything about what's the right thing for them to do. What I would say though is two things. One is that there are some medications that we know are more problematic when taking in pregnancy, and sodium valproate is the kind of top of the list there, and that actually is something that if you're taking sodium valproate, which is a medication prescribed for bipolar disorder, that really should be something that you talk, and in those your childbearing years, never mind thinking about having a baby, it's something you should talk to your doctor, your psychiatrist, your GP about. Other than that, for many other medications that women with bipolar would take, whether that's antipsychotics that are used to help keep mood stable, like quetiapine or olanzapine, which are often commonly used, or medications like lithium, which Claire mentioned in her talk. There's no really kind of right or wrong answers here. It all has to be weighing up the risks and the benefits. What I would say is that for many women with bipolar experience of bipolar disorder, the right decision for them may be to stay on medication through pregnancy and the postpartum period. For other women, the right decision may be to try to come off medication. So I think what I would say is the earlier you think about this, the earlier you discuss this with your team, the better, because potentially it could be that we look, the ideal would be to come off, if you decide to stop medication, come off that slowly. It could be that other medication might say medically advised. So these things take time to discuss. Bring this up. Talk to somebody about it as early in your thoughts about pregnancy as possible. Claire?
Yeah, definitely. No, I haven't got anything to add to that.
And Ian, I know you can't comment on individual circumstances, but someone's posted here just saying how they've been off. They've had one episode of bipolar. There was a one low, one mania with psychosis. And that was 7 years ago. Now they've been free of medication, stable for 6 years, but they're under pressure from the perinatal team to start medication either before or immediately after the birth as a precaution. Now, you can't advise them individually, but could you help them ask the right questions of that team to make sure that they are making the right decision? I think that would be the best approach, perhaps.
Yeah, I think so. There's a couple of things to say to that. One is, I think if somebody has had a experience of a significant bipolar episode, even if that's a number of years ago, then I think that is something that should be taken seriously. What we don't know, and what it's one of the things that we're addressing in our research program to try and understand better, is whether the time since your last significant bipolar episode, how well you are going into pregnancies, whether these influence your risk. We think and often assume they do, but we need more research on that. But certainly, I don't think in that particular case there's any definite right or wrong option. It's a matter of weighing those potential risks and benefits of all the options available, and really discussing that with the mental health team and coming to a decision together. I don't think any woman should. Claire might have something to say about this from the experience that she's had of supporting women. I often feel as a clinician, it's our place to come to a decision together about what the best way forward is, knowing that very often there isn't a right or wrong way forward. It just depends on an individual woman or an individual couple's thoughts about what the various options may be. So Claire, have you any thoughts or advice about how you can try and have those conversations with the clinical team?
It is difficult, isn't it? I mean, I think if she has that, well, I mean, one thing she can do, which, because I go onto the community quite a lot for Bipolar UK, and we have a very good pregnancy thread on there, you know, and she can put it on there and just get the benefit of other people's advice as well, because it is difficult, you know, for another clinician to say how you should approach this sort of thing in an individual circumstance. But I do think it's important to, if she really has all the information at her fingertips as to that, you know, she's managed to look into it, and I mean, obviously she's on this webinar, so she's finding out about things for herself, and you know, that you can go there with a bit more confidence then, and you've discussed it previously with whether it's your partner or a friend or somebody who you take with you, because I think they can sometimes be a little bit intimidating, these meetings. So I think you definitely need a bit of support, and you need, you know, so come on the community and see, and you'll get some support there.
Thanks, Claire and Ian. We can take a few more questions. Before we do, if you've really enjoyed the content, you found it useful, you want to see us have more of these types of sessions, and you want people that don't have much money living with bipolar to be able to access more of these resources as well, please do donate. So it's bipolar, just text bipolar to 785, and that'll donate £5. Or if you don't want to receive any more communication with us, which is perfectly fine, just type in bipolar no info to 785 and you can make a donation. And then it's all anonymous, and we won't send you any marketing communications. And thanks for those of you who have already donated. It's much appreciated. So going back to one of the anonymous attendee came straight out the doors when we first started with a question, which is really important because we know the interaction between the benefit system with bipolar is a really difficult one, and people don't get the access to the benefits that they deserve, and that's really difficult. So someone said here, anonymous attendee has said, do we have any rights to postpone DWP appointments until after birth of a child because it can cause a trigger? Do you have an answer to that, or would you be able to signpost them to somewhere that you could get advice? Claire, I think that's a definite there, isn't it?
Sorry.
I was going to say, Simon, it's not an area of my expertise at all, and I'd probably signpost people to Bipolar UK.
Well, I should know the answer, shouldn't I? Well, if you contact us in email us at info@bipolaruk.org, and we'll get a response to you. I would expect we'd signpost you to Citizens Advice, to a lot of advice in terms of being able to get free PIP payments and how to process them. A lot of people get turned down on their first time round, but then they can get support further down the line. If you are in work, a little known fund that the government deliberately doesn't publicise, but it can be really helpful, is Access to Work, which is a fund for people who are disabled to overcome their disability in the workplace. So usually it'd be used to fund, just say, someone who is deaf to have a sign language interpreter. But it is actually someone living with a long-term condition like bipolar can actually access it, and there is quite a lot of flexibility. So if you do need any resources and so forth, then you can put applications into that, and a lot of the time they can actually cover it. So that's worth looking at as well. But certainly, if you go to our e-community, there's probably lots of people who have been through what you've been through. I'll just type a little response on that in terms of the details for that, because those are the people on our e-community. It's about over 6,000 people on it. And if you have a question like that, I'm sure they'll be able to answer it. But again, if you want to message us at info@bipolaruk.org, and a member of the team who is far better researched than I am will be able to answer it. Right, so we've got a minute left. So I think that's probably it. We want to run more of these sessions. Really sorry if we haven't been able to answer your individual questions. Lots of really great questions around medication, which hopefully Ian's been able to give you the kind of the high level stuff on that, but always go to your GP and your pharmacist and your psychiatrist, and they'll be able to have a more hopefully have a more detailed conversation. It's been really wonderful how many people who've joined us here this evening. I really hope you're going away with some hope if someone's commented here, you can't mitigate the risk altogether, but there's things you can do to help. And I think a big thing to do to help is to take a bit of the pressure off yourself. Having a child is probably the biggest thing you'll ever do in your life, and certainly one of the most stressful. And having bipolar is incredibly stressful as well. So just be kind to yourself, be forgiving, try and plan for the future. And as Ian and Claire said, just go with the flow where you can. Any parting words, Ian and Claire, before we say goodbye?
Shall I start, Claire, and then you can have the final word? Yeah, so I think I just want to pick up something there. There's a lot of what we've talked about might sound scary, might be anxiety provoking, might sound negative. I think what I want to give you is the experience I've had of seeing women and couples over many years, and the vast majority of women, vast majority of couples with all the information make a decision that they do want to try for a baby. And for the most people, it's a very positive outcome. So I think, I think really what I wanted to get over is that this isn't something that people should feel hopeless about, but should feel very positive about. The fact that you people have listened to this webinar is they're doing what they should do, which is inform themselves, make those decisions with the basis on the information, but feel, but there is some positive here. Claire?
Yeah, I absolutely agree, and absolutely agree with that. And it can be scary, and people can get anxious, but really find out everything you can about it and do go ahead. I mean, it's certainly the best thing that I ever did, and I just can't imagine not being, not having my kids, or having somebody told me not to have kids and being without them. Just the thought is just awful. So please get as much information as you can, and take it really, really seriously, but don't get too anxious.
Yeah.
Brilliant. Thanks, Claire. Thanks, Ian. That was brilliant. And thanks, Kat, as well for hosting and organising and doing all of the back office stuff. Kat never likes to talk on these things. She's kind of organising everything behind the scenes. So thank you so much for organising it. I'm sure we'll run this session again in the future. So if your question hasn't been answered at all, because there's lots of really excellent questions around like IVF and other things, and what we'll try to do is weave it into the next one we do. And we're just talking about running a conference next year as well, which will Ian and Claire very kindly agreed to speak at. So there will be future opportunities to be able to get answers to those questions, and maybe you'll be further along on your journey as well, and perhaps come through the other side. So if you are pregnant and you're looking to give birth in the next couple of months, I just want to wish you a really massive good luck. Bipolar UK is always going to be there for you. Please, if you want to share your experience, we'd love to hear it. If it's something that went wrong and you felt the help service should have done a lot better by you, then we want to hear that as well, because collectively we need to be advocating for each other, because everyone should be able to have a good experience of pregnancy and a good experience of childbirth as well. And if the help service let you down, then we're there to stick up for you. So thanks for dialing in, and we'll join you hopefully for the next one. Have a wonderful evening. Thank you.
Thank you, Simon.
Thanks a lot. Bye.
Bye, everybody.